Okay. Hello, everyone. Hello from Zagreb, Croatia. Now we will try to tell you something about how does it feel to be a resident in Croatia. And first of all, first thing that we need to tell you is something about Croatia before we get to the point of being a resident. As you already know, or some of you know, we have many different places here in Croatia, many places to visit, many places to see, a lot of good food and different very nice stuff. So I would like to invite you to come once again, at least once more, and see all those very nice places. What do we have here except those things that I already said? We have Thai, we have many famous people. We also have, this one is my favorite one, Dalmatian guy. And there are also many other people who are famous and who have their origin from Croatia, but they didn't manage to get to this PowerPoint slide. And now when we talk about how does it feel to be a young medical doctor in Croatia, who is actually a young medical doctor in Croatia? It's usually a person. It's in most of the cases it's a girl who is 24 years old. She's in most of the cases clinically oriented, so she in average doesn't have a lot of interest in public health. And she usually, most of those girls who became young medical doctors live in Zagreb, but others live in Osijek, Rijeka or Split. And they have only one mission after becoming a medical doctor. The first one is to find and finish internship, and then afterwards get a medical license to work, and afterwards get a residency. As I said, clinically oriented mostly. At this very moment, according to data that we have in Croatian National Public Health Institute, in Croatia there are like more than 5,000 people who are younger than 40 years, and most of them, as you can see, are of course women, and less than 2,000 are men. So there is, I wanted to point out that there is a big feminization effect present at this very moment in medicine. Not only in Croatia, but these are the data for Croatia. And what I wanted to tell you is some interesting preliminary results of a survey that was conducted by Croatian Medical Chamber. The study was conducted among 1,531 young doctors, no matter are they residents or not, clinically oriented or not. And the main question was, would you leave Croatia and go abroad if you would have a chance, no matter for studying or working? And the answer in most of the cases was yes. So 60% of Croatian young doctors would like to go abroad, no matter the cause is. 1/3 of them doesn't know, and only 12% is basically happy here and would like to stay. I have also data about what were the main reasons for those people leaving the country and what were the most important reasons for staying in Croatia. And you can see if they answered yes, we would like to leave, that was almost 60%. They said that they think that better working conditions in European countries are the most important reason. They think that all the European countries have the improved healthcare system, and they think that they will have the greater opportunities there. And we also asked them what would be the main reasons for staying in Croatia, and there were two. Only the family reasons and contractual obligation, because when you start a residency in Republic of Croatia, you're obliged to sign the contract with your institute or hospital that gives you the residency. And that means for you, when you finish your residency program, if the residency program lasted for 4 or 5 years, after you become a specialist, then you have to stay for more 5 or 4 years working there. So that's the main reason, second main reason why would they stay in Croatia. And the fourth question was, from whom you acquired most knowledge during the residency? As you can see, the situation is not so great, because most of the residents think that they gathered most of their knowledge from the other residents and younger specialists. And this is basically the fact that I wanted to point out that our residents, as well as the other young doctors, actually don't trust the mentoring system here in Croatia. And we have a big problem with that. I think it's a similar situation in some of your countries, but I won't be so pessimistic. I wanted to tell you some also beautiful sides of being a medical public health resident in Croatia. What does it mean? Basically, there is 9 of us at this very moment, public health medical residents, and most of us work within the institutions, such as Croatian National Public Health Institute across the street, or Croatian Health Insurance Fund, or in different regional public health institutes. During our residency program, we don't work only in our basic institutions. We also have a master in School of Public Health, and we visit different hospitals. It depends on where you live and work. So, you remember all the comparison with your countries. I wanted to say that in a way we look at ourselves as endangered species, because here are 8 pandas. I couldn't find one more, and that is basically how we feel about ourselves in Croatia, about ourselves. But there is also the other side of the story. You all remember Euronet residency comparison from 2014. And this is the picture that is only visualization of number of residents per country. So you see, the green color is France. Each small little human is for, I think, for 10 people. So green are French residents, red are Italian residents, yellow Portuguese, blue Spain, and pink UK. The little blue guy at the end is Croatian resident in public health. So, who are those people? This is Damir, our only male resident, only one. And here are the names of the rest of us, all the women, 8 women. Maja, Vesna, Željka, Ivana, Iva, the other Ivana, Dubrovka, and Katarina. So, what do we face? We have to face a lot of challenges. I won't be telling you about all of them, but I tried to point out all of them that are most important for us. I think we have some similarities with other challenges with among all other residents in different countries, but this is something we are trying to fight with and trying to improve those things. At least we have a support from some professors, some people, and we are happy because of it. So at the end, every day I wanted to just tell you some stories that are very realistic. What happens when public health medical residents goes to a clinic? He or she can hear the sentences like, please give me your booklet, like a small booklet. It's a book where you get all the signs from the mentors on the clinics. Basically, we have 2 booklets, and we have to bring them with us. And you can hear like, please give me your booklet, we will sign you. I don't know what you have to do, just I will sign it so you can go home. And then you take the phone and call the Ministry of Health and ask them, like the lawyer within the Ministry of Health, excuse me, can we print all those competencies that are listed in our law just to copy them and just glue them inside the booklet. And she said, no, 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 you have to write them with your hand. And we were like, okay, it will take like us, I think, at least a week to rewrite all those competencies. Then you have a problem such as you cannot find your stethoscope, you don't even know how to use it sometimes maybe, and you don't know who your mentor is. All those professors, clinicians ask you, what do you actually need to do here? What is your job? I basically didn't know that public health residency exists. Who are you? And I wasn't aware of it. And such as and many others. But there is also a happy side of the story. On the national level, we have like our section of medical residents of public health. And there is also a commission for young doctors within the Croatian Medical Chamber. We have many institutions that we are trying to put our ideas through. And at the international level, of course, Euronet and specific public health institutes within specific European countries. And basically that's it, like a short review. This is my email, but there's also Euronet MRPH Croatia@gmail.com. Thank you.
Thank you.
So next, Paulina is going to tell us, unless anyone has any questions for Vesna. Paulina is going to tell us about how public health training happens in Poland. Hi, I'm going to tell you briefly something about the program of our training in public health for medical residents in Poland. I'm Paulina Nowicka. I work in the Medical University in Warsaw in the department which name you can see right here. And if anybody is interested in reaching Poland from Zagreb, it's less than 2 hours by plane, so it's very close. So at the beginning, what do you need to do to start your path towards public health specialty? Firstly, you need to study medicine or dentistry. Right now it's 5 years. It used to be 6 for medicine, but right now it's 5 years each. Then you have 13 months of obligatory internship at the hospital. And then you have to pass the national examination, which leads you to your chosen specialty. About the national medical examination, you can see the content. I show you the percentage of each field of medicine which is covered by the examination. It consists of 200 questions. They are multiple choice questions, and only 8 of them covers a subject of public health. Oh, and the medical examination is organized twice a year by the Ministry of Health at the same time. It takes, as I said, 4 hours. And after the national medical examination, they publish the list of placements in each district in Poland. So you have the red border shows the district, the Mazovian district. For example, it's like half of the Czech Republic. And for example, when I applied there was 1 place for the specialty in public health. So sometimes you need to wait for the placement to open in your region for half a year or longer, depending on the specialty you have chosen. So coming back to the program, it was written in 2014, so it's brand new. It's directly translated from the program. It is expected that the doctor at the end of the training proves knowledge here. And here begins the list of things you need to know. I translated just the bigger points. There are 18 of them, I think. So you can just skim through. Each of them has a lot of subsections. So yeah, several pages of just what you need to know at the end of specialty, which takes 4 years, by the way. And What else? What do you need to do during the specialty? It consists of self-study, of course, the specialization courses and internships. So specialization courses, there are 22 of them, and mainly they're organized by the Center of Postgraduate Medical Education in Poland. The internships, you have one basic internship, which is at the place that hires you. So it's called basic internship. And then you have 5 specified internships in the places that I'm mentioning here. And you can see the time frame of each of them. So it's the Chief Sanitary Inspectorate or local branch hospitals, research units, and governmental or administrative institution dealing with public health. And of course, the payers, the institution which holds payers' function in the healthcare system. After you complete all of this, you have examination, which consists of 2 parts, oral and written. And if you pass, you have the title of specialist in public health. Good luck. And if you have any questions or you want to mail me, here's my email address, and at the background you'll see yours.
Wow.
How many residents are there in Poland?
Right now, around 20.
20.
Yes, but there is also another path, because one path is sponsored by the Ministry of Health, so it's paid. Another one is unpaid. So people who choose the unpaid specialty training, they usually have different specialty right now. So they are working in another place, and in the meantime, they are doing the specialty in public health.
That must be very
They
enthusiastic about
need
it.
it for work reasons. Mainly, so.
Okay.
And do you have to do a master's of
No,
Irish?
we don't have to do masters. It doesn't cover the year of masters, because I heard that in some countries you need to do that. We don't. It's completely different.
Thank you.
Thank
You?
you. Thank you.
So next, I think, is Damir. He's going to tell us about a patient registry he worked on.
Yeah. Miguel, does it stay on YouTube after the live streaming, or
When it stays.
it stays?
Do you know this one?
Yeah. How many people watching? 4 people watching. 4 people watching. No, it's not.
Okay, so this is what I was paid for to talk about in Barcelona. I didn't talk about it. Right? So in short, I'm still in my first year of residency, but basically from the first day that I started my residency last summer, I was thrown into working on this project, and it's a joint action project. I don't know if you're familiar with joint action projects. So the point is that you have partners from multiple European countries. The projects are usually 60% co-funded by European Commission and 40% by institutions or countries participating in the project. And the project was called the Parent Joint Action Project. The Parent is a strange acronym for Patient Registries Initiative. Project, as you'll see. Okay, so I'll talk about my experience in the project. So I worked basically in the last 6-7 months of the project, which lasted for 3.5 years. The project itself was started as a response to a recognized situation, and that was a poor cross-border availability of health data for research and public health decision-making and public health use, especially in terms of patient registries. I don't know if you probably came across patient registries in your work in public health. I don't know in how much detail, but the scope of the project was to assess how well are the registries functioning, what are the opportunities of registries interchanging data. There are already some initiatives in the areas which make most sense, I would say, to connect registries from different countries, like rare disease. So you have registries of rare disease in different countries. It makes sense to connect 10 different registries and have a bigger volume of cases which you can then analyze, right? But the problem in combining these cases, combining or reusing registry data is that registries are established, designed, and run in a very different way from country to country, institution to institution, city to city. So my base institution, the Operation Institute for Public Health, was leading the work package 4. So these projects are usually consisting out of work packages. And work package 4 was called the mapping and analysis of existing registries on a European level. The project had 11 associated and 12 collaborating partners, which are marked here. The most active or important ones were, I would say, Spanish, Catalonia, Slovenia, Croatia, Finland, Greece. The budget of the project was co-funded by the European Commission, 3.5 almost million euros, and the rest 40% was funded by participating institutes. It was mostly institutes of public health from different countries. I send everything to this slide. Okay. So the field of work of the project were registries, and just as a reminder or education, the registries. This is the American definition, which was partly used in the project and in some project deliverables, which says that the registries are an organized system that use observational methods that collect, analyze, and disseminate data and information on a group of people which are connected or defined by a disease, condition, exposure, or service they received in the past or are receiving continuously. And they serve a predetermined scientific, clinical, and/or public health policy purpose. Right? This probably you know, but it's a nice reminder, I would say. So the focus of the project were registries and interoperability. So interoperability is like a concept that was very strange to me when I started working. Now once I got into it, I started applying it almost going shopping. Interoperability, you can apply it to almost anything, and what it basically says is the interoperability is an ability of two entities to communicate efficiently, to understand each other and to communicate efficiently. Talking on a registry level, and interoperability is through this interoperability framework, European interoperability framework, which is now in its second version, is defined through these 4 or 5 dimensions, which I call P-LOST, which is political, legal, organizational, semantic, and technical. If you take 2 registries from 2 different countries as an example, political context, and they want to exchange some information, right? So the political context would be that there is a will on a national level that these two registries communicate and exchange data. Next step is then to see if there is, what is the legislative alignment or what is the legislative framework? Is there legal interoperability? Is this data available for cross-border exchange? If not, why not? What are the methods? There are different methods for exchanging data inside the European Union and outside the European Union between the registries. Then there's the organizational interoperability. What are the processes? Are they defined, and what are the processes in different registries of exchanging data once you have the will and the right? So what are the processes? Then we come to the last 2 dimensions of interoperability, which is basically when you say interoperability, people think of these 2, but all of these have to be met, basically, and this is semantic. So when I say computer, right? So that we mean the same thing when we say the same term, when we use the same term. So if I say computer, somebody will think of a PC computer and somebody will think of a Mac. So computer is not, we don't have a semantic, let's say, interoperability on this level. So either you have to define it better or you have to be more precise in saying what you mean. And then the technical interoperability of whether we can exchange data. So can my file from a Mac computer be open on a PC computer? And that's the lowest level. Although usually, as I said, people focus on these 2 levels of interoperability. What the work package 4 basically did first, it reviewed the literature on patient registries in Europe, and then it did a large survey on more than 200 registries in Europe. And these were some of issues, the key problems, key issues that patient registries face today, or which they self-reported that they face. And this is, of course, funding, connected to that limited sustainability, legal issues concerning setup of the registry, data protection, and data reuse. So legal backgrounds differ a lot in different member states in European Union. Roles of different registry stakeholders, so people that give the money, people, organizations, right? People that use the data, people that provide the data, people that analyze the data, and how are these roles of different stakeholders inside and around the registry, how are they defined, right? Various modes of data collection, access and sharing, lack of standards, so this is connected to this process and semantic interoperability between registries, issues of data quality, context in which data is collected, and again, information quality, transparency, safety. So this was the thing that when we asked 200 registry holders what they think their biggest problems were in running the registry, this is what they reported. When we asked them what would they expect from a European level project that would help registries, although looking at here, we see a lot of political and legal levels of interoperability, which they have a problem with. But when we asked them, what would you like from a project like this? They didn't focus on political or legal and solving this kind of problems. They again focused on technical and semantic levels. So what IT tools would I use? How will I access these data sources? Only the legal advice here is something that was like a higher level of interoperability. So there was a clear mismatch between what they recognize their problems are and what they expect from a project like this. So this was a very interesting finding. Maybe I will skip this part because it will take too long, but this is what the registry looks like now, and the other registries are other small islands, and they're not basically connected. And this is the idea of how the registries in an interoperable settings would look like, where most components of the registries would be basically functioning as services. So it's like this service approach, where all other registries would basically continue on the existing one, and they would be able to operate together. So, what the project, so the parent project, what it brought in the end, it reviewed current state, it set up some coordination mechanisms. So this is different initiatives that the parent project was connected to. It piloted registry of registries, which I will show you now. It is this ROR platform. It divides the recommendations and guidelines on how to run projects and so on, and is now working on sustainability and support for its products. Basically, what we did in the project now, we don't want it to be a website which will die in 1 year and some PDF guidelines and documents which won't be cited from time to time and will be forgotten in a couple of years. So we want to continue on what we've done in this project in other initiatives and other projects. So again, this is mostly a repetition of this. And the big thing that parent did, I'm sorry I didn't bring the book, we made like a really thick book of 200 and something pages of methodological guidelines for efficient, I think they're officially called the methodological guidelines for efficient or something of registries. And these are the topics that are covered. There's a huge book, there's a smaller book, and there's a wiki version of this. So like a Wikipedia where you can jump from one part of the guideline to another. And what it does, it shows again this overview of registries, definitions, requirements for cross-border change, context, how to plan a new registry that you want to make, how to set up a registry, how to run it, all the way to interoperability, safety, and so on, to stopping the registry. So this is also like one of the topics that has not been covered in literature so far. What you do when the registry doesn't make sense anymore, and how to stop and close and archive the registry in an efficient and safe way, right? Because we are dealing with with personal data here in most of the registries, right? So this is what Wiki, I don't know the address by heart, but if you go to patientregistry.eu, you can find the Wiki version of the guidelines, where you can jump from chapter to chapter, and there's a lot of these hyperlinks. So showing you different, and it's called methodological guidelines and recommendations for efficient and rational governance of patient registries. So this is one of the deliverables of the project. And the other, and these guidelines, this was a big thing for us. By the end of the project, or somewhere around the end of the project, these guidelines were endorsed by eHealth Network, which is European Commission's, European Union's like, umbrella body for eHealth. So they were endorsed. When we did this first survey, we put all the data, all the publicly available data from this survey in a registry of registries. It's basically like a phone book of different registries that participated in the first survey. And here you can see which registry, which country, was their primary purpose, number of cases, was their observational unit, is it a patient, is it an event, and so on. Does the registry have a governing board? Is the data in this registry linked to other sources? And so on. There were a lot of criteria, but this was only a starting point. It was just a phone book of registries where you could find some registry, find out some details about the registry, but it didn't tell you anything about the quality of this registry and how interoperable it is. Can it communicate with other registries? So we were thinking, and this was a thing that, for instance, wasn't planned in the first proposal of the project when basically project got the money from European Commission. But I think we did these guidelines where we say how the registers should be run and how they should be able to communicate among each other. And we have this phone book of registries. So why not upgrade this registry of registries to version 2, where we included then all the registry. We are now still doing it. Although the project finished in our own time and on our own budget, we are continuing this project, because now we are calling these registries from the first, from the phone book, basically, and saying, can you fill in the new extended questionnaire? And after you fill it in, we'll be able to tell you how your registry scores. So basically there is a score, and you can see some areas for improvement. So you basically fill in the questionnaire, and according to the guidelines that we devised, your registry gets scored. You get notifications on possible areas for improvement, and you even get links directly to the Wiki guidelines if you're not sure what some question or some area of improvement means. So it's an assessment tool, the ROR, so Registry of Registries version 2. It's an assessment tool, but it's also a comparison tool where you can compare your registry to all the other European registries or to a specific set of registries that are similar to your registry. So for instance, we have a registry of Latvian Register of Patients with Particular Disease, Patients with Mental Disorders. It's scored 21 out of 42, so it has 23 areas of improvement. When you click here, you see what are these areas of improvement. What does the Wiki guideline, the new version has a link to Wiki guideline here, which is online now. What does the Wiki guideline say? What is this area of improvement? What are you supposed to do? And I mean, you can use this for self-improvement of the registry, but you can use this. I've heard from a lot of registry holders, they get this and they go to the people, to somebody who is above them, who gives them money or approval for something, and say, look, I'm the only registry in Europe that doesn't have procedures for data access and sharing. I need funds for that. I need people for that. So it can be also a good lobbying, I would say. So I think it's an interesting thing. We are now inviting some additional registries that participated in the original survey to fill in this, and we are getting some very nice feedback. And also from your side, I'll give you the link to this. If you are in contact or are working with some registries, which might be interesting to participate in this, I think this would be a win-win situation because the more populated this ROR is, the better quality of comparison you get to other registries, right? And of course, some additional descriptive statistics that you can get. For instance, this was a question of governing board functions. So what does a governing board, if it exists in a certain registry, what does it do? And then you can compare to different registries in Europe. What do their governing boards do? This is, again, the main page of the ROR. Here it says that you can do different things. So it's not only for registry holders. There is a public view of the ROR. There is a view if you're a registry holder. There is a view, hopefully in the future, if you're a national contact point for registries, for registry interoperability, which we are working on. So it's not a one-sided tool. It can be used by different roles, let's say, in the public health sector. This was the organization that we worked with. What happened next? So guidelines were endorsed. We continued to populate ROR2, maybe even video health. We are looking for national endorsement of guidelines and maybe establishment of national contact points for registry interoperability. There is talk about hosting deliverables as part of European Medicines Agency or Joint Research Committee, so that the project continues basically. And the parent deliverables will be used for definitely in these two projects. There are also joint action projects, so Euronet HTA, which our institute is now starting to work on, so it's the health technology assessment. They will see whether they can get some data for health technology assessment from registries, and how to identify registries which can give them useful data and how useful this data is, right? And the rare cancer joint action, which is again, it's quite self-explanatory. Our rare cancer registries and interoperability makes sense to get. And different other Horizon 2020 and inter-regional projects to come. It will be used, right? And that was a bit longer than I expected, but hopefully you understood some of the things that I tried to say. Thanks. Questions?
I have two questions. One is, I didn't really understand, do you have European registries as well, or just country level? So you know the European Congenital Anomaly Register, does that go on it as well?
If it's like a standalone registry, then it does. If it's a combination of different national registry, then we try to have all the national registries inside.
And if we have registries in our countries, how do we become involved with that?
Well, we talk about it later, but it's quite easy. You can go to this web page, parent I cannot see it. So I'll give you the link. It's parent registry of registries, right? And you get it there, and you can register, nominate your registry, fill in the data, and oops. Any other questions? Thanks.
Thank you, Damir. So the next presentation is from Italy about their website for vaccinations. And after Italy, we're going to have Portugal, and then we'll break, just because we have a few extra presentations.
I don't know. Sorry. Today we are going to speak about Vaccinassi. Vaccinassi is our website. Me and Paola, we are part of Vaccinassi website. In particular, we are taking care about the communication. So, Vaccinassi means vaccine yourself. And today we are going to explain you why we create, but we are collaborating with this website. So we are doctors, so
We know that immunization is very important, is one of the most successful and cost-effective primary prevention tools. Is estimated more or less that immunization prevent between 2-3 millions of deaths in the world every year. So it's cool. But we are doctors and we know, not all doctors. But nowadays, the people is increasing the vaccine hesitancy. And why? Because the risk of vaccine is perceived to be greater than the risk of the disease, because many people, the young people in particular, don't remember what's happened some years ago, like polio. Polio affected 60,000 persons. So between death and paralysis. And I want to show you what is happening in Italy, because I don't know here, I don't know in the world, but in Italy, 2 years ago, our health ministry said 25% of rubella and measles coverage is decreased. It's a big number. After this, the situation is not improving at all, because this is an example of polio. You know, you see, the coverage is continuously decreasing. So the consequence are that more frequently, every day, we listen about some child that died for measles, for whooping cough. And for example, I want to underline this case. In Rome, the last year, we had 7 cases of Haemophilus influenza meningitis. But what is the particular aspect of this episode is that there were the first case after 10 years. So this is to be reflect about. But this situation regards just Italy? No. I don't know if you know that some weeks ago in Belgium, a child died for diphtheria, and 1 year ago, I don't know if you listen about the case of polio in Ukraine, or the case of diphtheria that in Spain. In Spain, after 30 years without diphtheria cases. So the point is that this disease is coming back. And why? This is the point. Why the parents, the people doesn't want to vaccinate their children? Because of misinformation. Now the people are more literate. They go to Google and look for vaccine, and they find vaccine is dangerous. Vaccine cause autism. Vaccine cause multiple sclerosis and these things. So website is the tool mostly used. But in Italy, I want to say that even newspaper and mass media contribute to create panic in the people. For example, we had 2 cases or 3 cases where the judge said during a judgment, said, okay, it's true, there is a correlation between autism and vaccines, so I will give you money. So the people say, okay, it's true. So this scared the people. It's something that happened last year 3 times. because they just have no scientific skills to say these things. But they, some doctors in Italy are anti-vax. Don't ask me why, but it's like this. So one of these doctors was in accord to these things. So this is one reason for, because the people are scared. And so, what is the strategy to fight this war? The people doesn't want to listen scientific source or statistic source because they don't understand very well. They are more emotive. So we have to change the language and give them more assured, because the people are not stupid. They know that go in internet they can find something true, something false. So how we can reassure them? For example, with institutional source of information and Vaccinarsi is an institutional website, because our ministry gave the approval. And now I will give the word to Paola, that she will explain you how work Vaccinarsi.
Hello, my name is Paola Anello and I'm an Italian resident in public health, and I also collaborate with this project, this online portal, which is Vaccinarsi. So Vaccinarsi is an online portal which consists in a website, but also two social network accounts, such as Facebook and Twitter. And the portal was launched in May 2030, and it had received the institutional patronage of the Ministry of Health, as Michela said, and the Institute of Health, the Italian Institute of Health, and also many institutions of the national health system. We unite unites and the hospitals. And also we received the home code, Health on Net code, which is a non-profit, non-governmental organization that promotes the scientific information regarding health on the web. And this project was launched by the Italian Society of Hygiene and Public Health, but also many scientific societies involved in vaccination programs and policies collaborated to do this portal. And then what is the aim of Vaccinarsi? Is to produce and disseminate evidence-based, understandable information about vaccines, counterbalancing the misleading and erroneous information circulating on the web on the topic. And so this is the organizational structure of Vaccinarsi. We have one coordinator, who is Antonio Ferro, and one steering committee composed by 5 members, including the coordinator, and they define the strategy of the portal. Then we have a scientific committee which is composed by 20 members that are experts in the field of vaccination from the academia, but also from National Health Service. We have also an operational board who cares for the content of the website, which is made mainly by medical residents in hygiene and public health, 60 members maybe, and more or less. And last but not least, we have a communication task force, which is made by 4 residents in hygiene and public health, that include me and Michela. And we are looking for some new communication contents. These are the main section of the website. You can see that we have a section with information about vaccine preventable disease. So information regarding transmission, signs and symptoms, national and global burden with morbidity and mortality, and epidemiological data. We have a section concerning available vaccines. For the vaccine, we provide data regarding efficacy and safety, as well as vaccine recommendations, schedules, and doses. Another section is about vaccines benefits and risks. So we talk about what the population perceived, the risk perceived by population, and we discuss in a scientific method. At the last few sections regarding is against misinformation, where we take the theories of anti-vaccination movement and we criticize also with references and solid arguments the pro and cons section, where we comment in a scientific context. Recently, news appeared on popular press on vaccine-related topics, and we have also a new section regarding travel immunization, where this section focuses on vaccine recommendation for international travelers. And we have also some communication formats. For example, training video material, multimedia presentation, and tutorials targeting both on healthcare workers and the general public. Stories, brief essay with a storytelling approach that describe case record of disease that could have been prevented with vaccinations. And also comics used as an effective communication tool to communicate and educate about the benefit of vaccines. We have also a new section where we put the recent news regarding vaccinations and infectious disease that could be prevented by vaccination, and the events, relevant conferences, congresses, seminars in the field of immunization. And then we have also two social network accounts, the Facebook page, where we recently reached almost 8,000 likes. Our users are mainly females, which is also more active in sharing info and commenting on posts. The most representative age group is which goes from 25 to 44. And the average number of users to visit the page per day is 1,500. Which regarding the Twitter account, we have more than 500 followers. More than half are males, contrary to Facebook. Over the study period, we did almost 700 tweets. The average retweet is 1.3 per tweet, and the average as favorite is 1. We have also some special content only for our social network. For example, we made the polio campaign tool to increase the awareness from this important disease that we don't have cases in Italy, and also the Vaccimem, which are, you all know what are internet memes, and this is some examples. These are the results of the 2 years of activity from May 2014 to May 2015. We had 800,000 single user access. 22 of them accessed it for more than once, over 1 million visits, and the average visitors per month increased from 10,000 to 60,000. Most of us were males, and the age group most representative was that goes from 18 to 44, and the vast majority of users came from Italy, and also from Switzerland, USA, and UK. Thank you for your attention.
How many children are vaccinated in Italy? Like how many percent?
Well, it depends on the vaccine. The lowest coverage is the rubella, measles, and mumps. Mainly 80%, and
And the obligatory, because we have a different
Because
system.
there are
It's
mandatory.
obligated.
No,
NPR
mandatory.
Yeah.
Aren't mandatory. So the mandatory vaccine reach also 90%, but not non-mandatory vaccines, the coverage are lower. So
Which ones are mandatory?
Hepatitis, tetanus, diphtheria, polio, whooping cough,
yes,
another one.
hepatitis B.
And what
And
happens
they're all-
when you don't take it?
Well, nothing at all. It's mandatory, but
The people are scared. The state can't obligate to vaccinate. Okay, it's mandatory, but can take the children
No.
and
But recently, in Italy, there is a debate regarding this topic because we are thinking to not allow children that are not vaccinated in the schools.
Yeah.
Can you approach the laptop? Because people on the streaming cannot understand what you're saying.
But for the moment, there isn't any kind of measure to against this problem.
Why is the measles and rubella, why is that not part of your recommended mandatory schedule?
Mainly for historical reasons, because the first vaccine were when it adopted the mandatory vaccine were
but even because the side effect of disease less maybe.
There isn't a clear policy around vaccination in Italy, but we are reconsidering them. For example, in Veneto region, where we study, we have abolished the mandatory for vaccination, but we increase funding for information to the population.
Do you know approximately what percentage of young girls get the HPV vaccine?
Yes, it's 70%.
Quite okay.
So,
Yeah.
That's the most, in Ireland, that's the most, controversial.
And do you have like certain areas, there's less vaccination because of
Yes,
religion?
Veneto is because we remove the mandatory, the coverage is lower, or but Friuli too.
Do you have any information of the impact of the project? Like some kind of evaluation that happened before the establishment of the project and afterwards?
It's too much difficult to
The
detect the result because in the last period we have no.
Not for now, but
Not for now, but we'll see. But we haven't done any study regarding this.
so, but in the future you probably will.
Yes, it's just our website, so it's really difficult to manage all the people that take information.
Okay.
The only things that I can say you that is becoming really popular, like a website, because we don't have other institutional website that speak about vaccine. This is the only one, and
Patient friendly.
yes, and especially during the city is our organization for public health professionals, and always there is our the owner of a website that explain to the other professionals the importance. So we are becoming famous step by step. We are.
cool.
Okay, so we're just gonna have Miguel do his talk, and then we'll go on the break. Okay?
Okay, so hello everyone. For this presentation, I'm going to give you a short update on some of the things that are concerning the public health physicians in training about public health in general. And in the end, I'm going to also show you a bit of a cool tool that we have regarding mortality in Portugal. And I hope that it can be something useful also to you and to take back to your countries. As a bit of the points that we're going to go through this short presentation, I'm going to talk about a new regulation regarding our residency program, because it's something that I'm not quite sure if it was approached in the last update in the meeting, but again, it's something that we're still dealing with. A new ambition for public health, which is something that is a new thing from the part of our government, which is cool. The 4th anniversary of our newsletter, or for Euronet in Portugal, which we're celebrating. A topic about the youthful wave that we're seeing in residents in Portugal at the moment, and also some of the sound bites regarding news that are coming up in the public health area or in medicine in general in Portugal. So regarding the residency regulation, so this is a regulation that was changed last year, and because of this, what happened is that the country is not that big, as you know, but still we are quite divided according to different administrative regions regarding health. And so what happens is that before, the southern area, so there's 3 different ones, so Lisbon area, the Alentejo area, and the Algarve area, were all together in one single area. And that area had representations from the part of public health residents, now is divided into 3 different areas. This kind of turns the regions a bit more similar to the NUTS, NUTS divisions too, but still is not exactly the same, because the Lisbon area, as you can see, it's still a bit bigger than the NUTS too. However, this ended up affecting us as an organization, because we had a specific structure who was representing the entire South. So now, since there's 3 regions, we have to find people to represent each of the regions. And so since the Algarve and the Alentejo have a smaller number of residents, it has been a bit difficult to find people that want to also work on the Euronet structure. And because of that, we're still struggling a bit, but we already have people from Alentejo. We're now trying to get people from Algarve. And that also is going to make us reshuffle a bit the way that we work. And this is important because as I was saying, this change was recent, and so the elections occurred in last December, which I came on board for the part of Lisbon. Alentejo just got on board in the beginning of January, and they ended up being first-year residents, so they're still very new, and we still have to find people from Algarve. And again, and this is important that we follow the structure, also because in the new regulations, the representation of residents has a bit more formality and is also more empowered to speak up towards the institutions that organize our residency. So for that part is a really positive measure, so that we can try to influence for the positive, the kind of education that we receive. Also, and because of this new division of the country, so to say, we also have to readapt the regulations that we had internally regarding how do we deal with the international aspects, in terms of the national, how do we coordinate our work. And since we're also managing to be more united at the national level, since before it was quite focused on each region, that also is boosting up the collaboration, and we also want to try to do more things with what we are capable of doing. And then a new ambition for public health, which is a very, very happy thing for us, because we do, and residents in special, do believe that public health has to be renewed in some way in Portugal. So that's a very positive thing. This comes from the new government. I'm not quite sure if you're aware, but we have a new government in Portugal since a couple of months back. And it was a bit controversial because the party who is governing the country was not the party with the most votes, but it was the party with the most support in the National Assembly. So this is pretty much common in other countries of Europe. In Portugal is a new thing, so there was a bit of buzz about it. Nonetheless, and the important thing here is that we have a new Ministry of Health, which actually a new Minister of Health who actually is a public health specialist. So hopefully also quite aware of the things that need to be done. And one of the things that he's putting into place are a bunch of reforms, or at least works so that we can come to reforms, whether on the hospital side, on the primary care side, and also on the part of public health. And even the part of the public health, one of the things that he's pushing forward is a new ambition for public health. So it's actually the name of the program, so to say, is a new ambition for public health. So nothing new from our side, is actually something that they were saying. Some of the things that they're pushing forward with this initiative is that to create, and it was recently launched, the first steps of a new national program for health literacy and self-care, so that people can be more literate about health and how to be more healthy. They also trying to push, again, for the local levels to have local health plans in line with the national health plan that exists, so that everything is aligned and trying everyone to be pushing towards the same direction. Again, we're also trying to boost a bit more the epidemiological surveillance systems that we have. We're trying to make them a bit more intuitive, and since we recently changed the platforms that we use, because before it was all paper, now we have an informatics system that we can make the notification of any kind of transmittable disease. And so everything is online now, so that hopefully will become a greater tool than what it was a couple of months back. And again, the focus on the health promotion that we want to also have, and that we agree that we need to go in that direction. And this is also positive because there's a task force working on specifically this part of public health new ambition, and the residents tried to get in the task force. Initially, the first reply was not that positive in our perspective, but again, we were able to talk with the coordinator of the task force, and now he was quite more open to our ideas, and we'll hopefully be working together with the task force to try to boost things forward, since the new group of residents that is now in training is, in terms of number, almost as big as the number of public health physicians, specialists in the country. So in in 5 years' time, the residents now will be the majority in the public health area. So again, it would be really important that we would be heard in this process, since we will be the ones implementing it when it comes to time. Then we have an anniversary that is very recent within our organization, which is the newsletter. We decided to celebrate this with a new design of the newsletter that we have. So before it was a bit plain. So what we now have is a bit more elaborate and a bit more fresh and new. So that's one of the things that is quite recent in our organization. And again, just to let you know, something that we were talking about, the youthful wave in public health and in Portugal, is that right now, and for the last couple of years, the number of residents to get in public health was quite short, but it's been increasing for the last couple of years. And this is bringing also some positive things and some concerns. In terms of the concerns, this is because, and maybe you heard of it, in Portugal, we're also getting to the point where we have too many medical students for the number of spots that we have in residency spots. So this has already happened in different countries in Europe, so it's now happening also in Portugal. The last year was the first year where you had people outside of the program because they couldn't get in a residency spots. I think it was 117, if I'm not mistaken, 117 people who didn't get a spot. So this is a new concern for in the field of medicine in Portugal. But again, because there was a pressure so big, the number of spots are also a concern for a lot of people. So they try to push towards the limits that they can have. And so we're having a bit of concerns if all the spots that are open are all quality assured, let's put it this way. So it's one of the things that we've been concerned about in the last couple of months, because we want public health residents, but we want them to have a good quality, a residency with quality. Also because if it sucks, people will quit, since public health residency was one of the residencies in Portugal who had the highest number of quitting along the term. So again, it's something that we want. And with this, and as I mentioned before, right now we have about 46, give or take, new residents in the first year, and this has been the biggest number in 1 year. So, and this probably will continue in the next couple of years. And then to finish this part of updates, a bit of some of the sound bites of the news that are coming up in Portugal. First of all, there recently, and this doesn't affect too much public health, but it's, well, indirectly, even though indirectly it does, probably also in your countries, residents are quite the weakest link in terms of work. And so in Portugal, this was particularly concerning in on-call work, where there could be the case sometimes where a resident would be the responsible for an ER area where the specialist should be there, or it's available through telephone call or something like that, but in reality, we all know that we're not going to call our boss at 5 a.m. in the morning, so this kind of stuff. And what happens is that the medical association and the administrative entity of the Ministry of Health in Portugal came up with a regulation that said that, for example, residents cannot be alone in the on-call room. They have to have someone who is responsible, and if they are alone, then a specialist has to be responsible if something bad happens. And since it's a kind of a mandatory thing, it's raising some concerns, because at this point, the residents are the main workforce for on-call work. So it's one of the things that is causing some buzz around. Something that also is causing some buzz, it's the euthanasia topic. Recently, there's a proposal in our government to actually liberalize it and allow people to do euthanasia in case they wish for. And the medical order is, the medical association is not being too active about the topic specifically, is just for now advocating to have better conditions in continued care rather than a push for euthanasia specifically. But there was the responsible for nurses in a talk show on the radio said that this is already happening in Portuguese hospitals because doctors would do things on purpose to cause the death of someone. So that came quite as a shock. And so that was something that was also filled quite a lot of pages in terms of newspapers and so on. Two more things. One is that since we have a quite leftish government at this point, there's a lot of things that are trying to push forward. One of the things would be to have less hours in the work week, because with the Troika, as you probably know, Portugal was under, kind of is, in a financial program by the EU and the European Commission and other creditors. And so the number of hours per week of work increased in the last couple of years. And so now one of the pushes is to cut it back again. And lastly, one of the things that just happened yesterday on April 1st, and it was not a lie, it was not a fool's prank, is that we now have all kinds, or there's a possibility of any kind of prescription of pharmaceutical components can be done completely online without any kind of paper. So you can pretty much go to the doctor, he or she will prescribe you something. You don't have anything like physical evidence, because it's all done electronically with our ID card. And so you go to your pharmacy, and the pharmacist will check for your health number, and it will see, okay, you have here this kind of prescriptions. Which ones do you want to get? So at this moment, hopefully, everything is working paperless across the country. So that's a new thing that I hope that the systems are doing well. And so in terms of news, this is it. And just to finish, I would just like to show you a platform that we have, which is about 1 year, give or take. And it allows us to see, let me just try to open it here. It allows us, anyone actually, to see how many people are dying in Portugal almost live in terms of information. It will show you in terms of numbers only, and it will also show you the causes of death of people, as well as according to months, to years, and it has a back term. Let me just find this here. And you actually can also look by yourselves, because it's in Portuguese but also in English. So it's also something that you can take a look at. And I hope that this comes up. And I apologize, I should have loaded this beforehand, but I thought that this would be quicker than what is currently happening. Okay, so let me. Okay, so this is the system. So here we can choose. We have the numbers and the days of the week with that divided by neonatal or otherwise, and then this is still loading up. Okay. So here we have. Let me try to see if we can have it a bit less. Okay. So we have here the different years of mortality data, so we can see how things are going. The red one is the current one, as you see, because today the data has not been messed yet. But we have by year, we can see here according to the age of the person when they died, and we can see also specifically for less than 70 years of age, for example, to get more specific data. And here, causes of death, or manner of death, as they put it. And we can put it here to see specifically external causes of death also. So everything in a graphic manner and everything updated to the time. We do have an informatic platform, so every doctor in Portugal, all deaths have to be certified by a doctor. So the doctor now has to, instead of doing a paperwork, they go to the platform and they do it electronically. So since it's electronically, we can immediately use this automatically and put it out live to anyone that is interested in seeing it. And that's it. It's a simple thing, but with the change of procedure, it gives us data that we're now trying, and hopefully, eventually, we'll get to the point where we'll have the data divided according to municipality. Because right now, the divisions that exist are also only to north, center, and south of the country because of administrative regions. There's a bit of a problem there. Because as you could see, the NUTS division is different from the health administrative division. So there are some problems there, but hopefully we'll get there. And that's it. So.
Is it just about mortality?
Yeah. Okay, sorry.
It's just data about mortality and not other pathologies.
No, it's only causes of death. You can see the causes of death there, but for now it's this. There's other platforms, but the strongest one right now is this one, at least with publicly available data. This is the one.
We could define this big data, or
yeah, it's pretty much
sort of big data project.
Yeah, it's something that, again, it was something that we have an organization which is involved with the part of of the EU electronic parts of the projects. Let me show you here, because the SPMS, which has its logo here, this institution is the responsible in Portugal for everything regarding electronic systems, even though it's a bit tricky because you have the central administration and you have this entity. And this entity is responsible for electronic health records and so on. So they also try to show you to the common citizen what they're doing with data. And so it's something that it's fancy, it's something that was simple because it was electronical. So, and also the person in charge of this is really pushing for a greater accessibility to data and to information. He's probably also involved in the project that Amir just mentioned before. So that's one of the things that they're doing.
Thank you.
Okay. Thank you.
So we're going to stop now, have a short break. What time is it? So we'll start again at 20 to 4, so 10-minute break. And for those at home, come back. We'll have malaria, sexting, sex workers, and social determinants of health.
Yep.